So it's my pleasure. Today we have two guests. So we have Dr. Maria Cristina Ospina, who's a movement disorder neurologist practicing in the Phoenix metro area. And you already have spontaneous hand gestures in the audience, Dr. Ospina. So if you have heard Dr. Ospina speak online or in person, put a note in the chat because you are internet famous, Dr. Ospina, and I always appreciate your skill at breaking down complex issues and being able to explain them. You use metaphor so well, and you're just so practical at, taking very complex information and crystallizing, okay, but what do we need to know? What's relevant to our lives? So excited to have you join us today. And we're going to be talking about research and 2024, new treatment options, new medications on the horizon. And we all know clinical trials, before we get a new medication approved by the FDA, we need research. We need clinical trial data. So I will now turn it over to Dr. Ospina and Mike, who are going to get us grounded in the issue and talk about some actual clinical trials going on. So I'll kick it over to you, Dr. Ospina, and maybe you want to explain kind of Mike and how you do research with that firm and what we're about to learn about.
Yep, thanks, Andrea. And actually, if you want to put that slide up from June of this year of all the clinical trials from phase 1 to 4 that are available in PD, so you guys can see how much research is actually being done in Parkinson's disease. These are all of the trials that are currently out there enrolling in Parkinson's disease. And what we need is just the subjects to come in and enroll so that we can sort of close the loop and get these new drugs out to you guys. So, everybody's excited about the pumps and IPX203 and stuff like that that's going to come out next year. But all of those medicines and therapies had to go through this part to get to us in the clinic. And what we need, the most important part of that is those subjects to enroll in the study to prove that it's better than a placebo. So that's how Mike comes in, sort of outfits like clinical endpoints where we do clinical trials. And here in Phoenix, we're blessed to have a lot of different places. We've got Barrows, Mayo, Sun Health Research Institute that are doing clinical trials. We just need to find the people to volunteer for those trials. So Mike, if you want to get started and talk about what we do at clinical endpoints.
Yes, absolutely. Share there. Can you see my slides?
Yep.
Wonderful,
Sure can.
wonderful. So like Dr. Ospina said, here at Clinical Endpoints, we are what we call in the industry here a clinical research SMO, which for our individuals out there, we are a clinical research or clinical trials site. And so we work very closely with what we have as the sponsors to run those trials. So I'll kind of give you an overview of what that kind of looks like here with us, talk about our goals here specifically with clinical endpoints, as well as how they kind of match across the industry for these trials. I'll talk about our portfolio as well as studies that are enrolling here and across the nation, as I know everybody is not necessarily located in Arizona, where we are and where Dr. Ospina is right now. And then I'll be able to take some questions, and if I can answer them, luckily we've got Dr. Ospina here who will be able to probably fit in anywhere that I can't. So I appreciate everybody taking the time out of their day today, and thank you, Dr. Ospina and PMD Alliance, for letting me come along and give this information. So we work specifically with a larger group, which will kind of track with everybody that is here across the nation and even internationally, called Imaging Endpoints, who focuses specifically on clinical trials for images, and they help and support us in our clinical trials for neurology-focused studies and diseases. We partner closely with a lot of other organizations, like Dr. Ospina said, here in the Valley, such as Honor Health, Simon Medical Imaging, Four Peaks Neurology, and Callan Neurology, just some more specific groups here in the area that we help support to run these trials. And our goals here at Clinical Endpoints is to provide concierge level service, not only to our patients, but also to our providers. We are led by doctors such as Dr. Ospina and other board certified neurologists, and we partner with them specifically to help them navigate their patients through the clinical trials pathway. A lot of times either patients aren't aware or doctors might not be aware of what opportunities are out there for their patients in these fields. And so we pride ourselves on connecting with the doctors and the patients to help them seamlessly move from being their regular clinical treatment to adding on this extra opportunity that they have out there. We work closely with our community partners such as PMD Alliance and our other specific providers that we work with to ensure that we're going to have a large and comfortable portfolio that does provide the best opportunities for the patients in our area. Now that may look different for us here, specifically in the Scottsdale, Arizona area, but there are sites, like we've said, across the whole country. And so I will give you some resources of where you can find areas and sites that work for you if you're not obviously located in Arizona, or if you're not sure what in your area may be of an opportunity for you. Our current portfolio here is, like I indicated, we are focused specifically on neurological diseases. We have done a few other areas of disease studies, but right now we are honing in on neurological diseases, specifically things like Parkinson's disease, and I'll talk about some specific studies we have opportunities for. We also work with essential tremor, migraine, Alzheimer's disease, and multiple sclerosis. So I know today we're focusing on the Parkinson's disease, and I'd just like to let everybody know kind of all the opportunities that are available for you, your friends, your family members. There is research going on through the country and a large area of diseases. I'm always looking to kind of progress how we understand all of these. And these portfolios at sites, which is nice. If there isn't something in your area that looks like a good fit for you or you're interested, clinical trials are always starting and finishing, and so there's always something new on the horizon that's coming out. Currently, I'll come to that side next. Currently, we do have 2 studies that are looking specifically at individuals with Parkinson's disease. And they are, what's exciting is kind of looking and focusing on 2 different types of Parkinson's disease patients. One of the studies, it's called the InhibiCase study that we do here, and it is happening across the whole country, is looking for individuals that are new in their diagnosis and don't have or have not taken any medication. And while we know that's not a large quantity of individuals in this area, they're looking for that because the medication is looking to be a new standard of care medication, and really focusing on the pathway of Parkinson's disease instead of currently where a lot of the medications are symptomatic medications that are wonderful at helping patients with the symptoms that come with this disease, but haven't shown too much pressure on the actual progression of the disease. So it's an exciting new study and medication that's coming out that I know Dr. Ospina and some of our other providers have been excited about, that we were able to function with. And there's probably a site in your area that is also offering this opportunity. The other study that we have coming up is looking for a different type of Parkinson's disease patient, and that is somebody that actually has had a diagnosis for 5 years or longer and is on that standard of care, that carbidopa-levodopa, that is pretty well used across the disease and for treatment. And the goal with that new medication is that it's hoping to be a supplemental medication that will allow for patients to be on that carbidopa-levodopa for longer periods of time without having to increase the dosage, as well as hopefully lowering some of the instances of those side effects that we know patients do see while they're on that standard of care medication. So kind of the idea of a complementary medication that can help us not have to run through and increase that pressure on the carbidopa-levodopa quite as quickly. And those are the 2 that we have. We're always looking to bring more studies on. If you are interested, or there's ever any questions about what studies are in the area or what studies we're doing here, like we've said, my name's Mike Callan. I'm the site manager here at Clinical Endpoints. We are located in Scottsdale, Arizona, but I am happy to help field, questions or if anybody is looking to get involved or engaged and kind of help you in your area or wherever you're located as well. So this is my contact information. And we'll go ahead and ensure that this gets sent around. And like I said, even if you're not located in Arizona, if hey, I heard you talk with the PMD Alliance, I'm wondering how I could get involved, I'm happy to field those questions and get you connected to the best way possible. A resource that I did not get on my slide here, unfortunately, I'll get it on the slide before we send it out, is that clinicaltrials.gov webpage. It's actually a very, very wonderful database of all the clinical trials that are going on currently in the nation. And you can put in either your location, or you can put in what disease you're looking to get a study involved in, and do different radius, and it will tell you all of the sites where they're located, the studies that are happening, and it even gives contact information for a specific individual at that location. So you can go to that webpage and it will tell you specifically, if you're located in Tennessee or Texas or New York and you look for your specific area, it'll then give you contact information for a person located in your area. And I'm happy to help navigate that for anybody that would need that as well. If you are located in the Arizona area and interested in getting involved, whether that be with Parkinson's disease or studies at all, please feel free to reach out to me directly. We do kind of keep a running database of individuals that are interested. And even if we don't have something now for you, we can always get in contact with you once we have something that does come open up. I may have moved a little bit quick, as I tend to speak fast in these situations, but that is kind of everything that I have here. I'm happy to field any questions if any popped up in the chat. If there's anything I can answer or any questions in regards to clinical trials that we have, I'd be happy to field those now.
Yeah, thanks, Mike. So as Mike said, right now we're enrolling 2 studies. So one's for a disease-modifying agents. Remember, all of the medicines that we currently have for Parkinson's disease are just managing the symptoms. And of those, they just help the motor symptoms of PD, like tremor and rigidity. They make non-motor symptoms like low blood pressure, confusion worse. And the inhibicase study is actually a disease-modifying agent, something that could maybe stop or reverse your PD symptoms. So we're kind of excited about that. We want to be like MS, where we have disease-modifying therapies that are available to patients, but we can only get there if we can enroll patients. And it's been hard finding patients who are newly diagnosed, have symptoms, but haven't started medication. So those are the patients that would be ideal for this study. And then the other studies for, I think it's a dopamine agonist. So it's an adjunct for patients who are on levodopa. And so I think it's a D1, D5, so less side effects than the current dopamine agonists that are available today. So now I'll just open it up to questions. We'll do our usual Ask the Doctor. So you guys go ahead and start asking questions.
Yes. So I have one that someone sent in the chat. So Mike or Dr. Ospina, do you need healthy controls for the trials in Scottsdale, or just people? There's someone who is a spouse of someone with PD who wants to know if they could do it together.
That's a wonderful question. Currently, the studies that we have are only looking for individuals with diagnoses. Now, that's not to say that we won't have studies down the line, or even studies that may not be specific to Parkinson's disease, but may be looking for healthy controls as well. So if it's something where you would like to stay in the know, or at least like to be aware if there is that opportunity, those studies do exist out there. We don't have any currently enrolling, but if it's something where you're interested in getting involved at all, I'd recommend either reaching out to me and I can keep you on our database of interested people, or look into that clinicaltrials.gov webpage, and you can even type in healthy control and it will show you all the studies that are looking for individuals with healthy controls.
Thanks, Mike. So if anyone would like to be unmuted and ask a question, you can put it in the chat or just do the little hand raise and we'll unmute you. And we do have some, oh, they're coming in fast and furious in the chat. So first off, Dr. Ospina, could you explain again why this trial needs people to not be on medication? So I'll stop there.
Right. So this trial, so we need to know that you got better because of the new agent, that's what made your Parkinson's better, not that we gave you levodopa and sort of erased your motor symptoms. So that's why that patients have to have a diagnosis of Parkinson's disease, have symptoms, motor symptoms of Parkinson's disease, but have not started medication, and be able to stay off medicines for 12 weeks. That's the length of the study, so that we can prove that it's the c-Able inhibitor that's improving your symptoms of Parkinson's disease, not the therapy that we gave you. And these are exciting molecules because these are inhibiting the, that alpha-synuclein, that misfolded protein that's causing all of the trouble in Parkinson's disease from getting into the cell and starting that cascade of cell death, which is causing the disability in Parkinson's disease. So, we want these kind of agents so that we can either stop the progression or make you guys better with this therapy rather than just treating the symptoms.
And that's why everyone on this call, I give you a little bit of homework. As you meet people who are newly diagnosed, whether they're in exercise class or in support group, and they're not on medication yet, the research community really needs them. So I encourage you're learning about this. Like, if we want a cure, if we want medicine that will slow the progression, we need those people to enroll in trials. So if all of us here and everyone watching on YouTube in the future has our ears out for that, and as you run into people, oh, I just got diagnosed, no, I didn't start Cinemet yet, how can we bring them into the community, explain how important they are to researchers, and light that spark to get them to enroll. That's all of our homework here today. So, okay, we have some more questions. Let's see. Cindy B, we're going to unmute you and let you ask your question.
Well, I have a question. Now I have a suggestion. I used to work with PDF, the Parkinson's Disease Foundation, on recruiting patients for clinical trials. And for patients who are not yet medicated, if you're looking in the data to the people seeing movement disorder specialists to get a pool of people, they're not there. You want to get people who have not seen the movement disorder specialist yet. And if there's some way to tap into the general practitioners who are referring their patients to neurologists, that may be a better source. I know a lot of patients see an orthopedic surgeon before they see a neurologist because they think there's something wrong with a limb. But I think you need to back up a little bit in the, someone who's having, I don't know, some of the early symptoms, whatever doctors are seeing. I saw a physical therapist before I saw a movement disorder specialist. A movement disorder specialist was last on the list. And you might want to check in earlier. I have a question not about newly diagnosed patients, but about oldly diagnosed patients. And are there any clinical studies that we can join that might be testing things that help people later on in the course of their disease? And like, for example, when I was diagnosed 20 years ago, Azilect was a new big deal, and they didn't know if it really slowed the progression of the disease or not. But now we have 20 years of data. Like, do we know if it slows the progression? So those are a couple of questions I have.
Absolutely. I think, Dr. Ospina, that last one will definitely probably be more up your alley. As to your comments about where we find these newly diagnosed patients, you're 100% correct, which is also why, and I think Dr. Ospina and PMD Alliance for letting me come to something like this, because what you spoke about is exactly the situation we run into. We're highly connected to our specialists, but a lot of times patients won't get there until they have already had some of these other opportunities done. So we are working really hard to try and bridge that gap and really kind of get involved at the very beginning with, our general practitioners, your PCPs, the community at large, letting individuals know that these studies exist out there, and hoping that, as that word gets spread kind of across the community, those conversations are being had. As for studies specifically for individuals that are kind of further down or been diagnosed for a longer period of time, we will have one other study opening up coming soon that is looking for individuals that actually have been diagnosed for 5 years or longer and are on that levodopa standard of care medication, with the goal of this extra kind of additional complementary medication to lower some of the side effects that are seen with that medication. So they do exist out there. We will have one that's coming, as well as I know there are plenty of other ones out there. So those opportunities do exist for patients, such as yourself and others that have had that diagnosis for a long period of time. As for the question specifically about that other medication. I'm not too well educated on that. Dr. Ospina may have a bit more of an update on that.
Yeah, thank you. Especially people, I'm an outlier. I mean, I've survived, I was diagnosed 20 years ago. I'm still kicking and still walking and still with a rollator, but I'm still very active. And people always ask me, what did you do to be able to do well this long? I don't know what I did. I do strongly believe in chocolate. I think that has some value, but I don't really know. And I'm wondering if there are studies about why some people do better and some people do worse.
Yeah, so one thing, so you can always enroll with Mike, and he keeps a running list of patients with PD and MS and Alzheimer's. And so as new trials come up, then he calls them up and says, hey, would you like to be part of the study? And remember, here in Phoenix, I don't know if you're in Phoenix or not, we've got lots of sites. So Barrows is doing clinical trials, Mayo's doing clinical trials, Sun Health Research Institute is doing clinical trials. So you can always look there to see if there's anything that fits your profile. And then as far as electrorazagiline, which is an MAOB inhibitor, so the Adagio and Largo trials, showed that there was some promise, but eventually we couldn't prove that razagiline was disease modifying. So it's just approved as a monotherapy and as an adjunct to levodopa. So currently we don't have any disease modifying therapies in Parkinson's disease. And remember that PD, what we say in the clinic, once you've seen one PD patient, you've seen one PD patient, because everybody has their particular sort of flavor of Parkinson's disease. And that has to do with whatever gene is involved in your case and whatever toxin turned that gene on. So because everybody is different, everybody's sort of progression and response to medication is different. So just because your neighbor takes this cocktail of 3 medicines doesn't mean that it's going to work for you or that you're going to have the same kind of progression. So that's sort of what keeps Parkinson's interesting.
Chocolate. That sounds like it has some,
Chocolate and exercise. That's a good combination.
Okay, Dr. Ospina. Okay, we had a question about pumps. Last year, it seemed like pumps were the next great thing and they fizzled out. Haven't heard anything. Can you tell us more?
Yeah, so they haven't fizzled out. So what happened is that the FDA asked for more data for 2 of the companies. And so that has delayed the pump coming out to the clinic by 6 to 9 months. So we hope that in 2024, we'll have at least 2 pumps and that NeuroDerm might be approved for compassionate use. So the first pump that should come out should be the Supernus apomorphine pump, which is a dopamine agonist. And it hopefully will come out the first half of next year. And then the AbbVie phospholivodopa pump should come out in the second half of next year. So they haven't fizzled out. They're very much still there and active. And we're sort of waiting for them with bated breath. And the reason that we want these pumps to come out, because right now, the current pump that we have is Duopa, the AbbVie pump, which requires a PEG-J. So you need a little medication port that goes into the tummy to use the pump. But lots of patients have trouble with the tube. It falls out and it's hard to keep that stoma clean. And so many patients, although it's a very good therapy, they don't want to deal with the hassle of having a PEG-J. The new pumps are going to be subcutaneous, like the insulin pump. So it doesn't require a surgical procedure. There's no little medication port that goes into the tummy. There's no tube or anything that comes in and out of the body. It's just on the skin and it has a little cannula. So it's much easier to put on and off. And if you don't like the therapy, you just sort of take that thing off and go back to orals. But why do we want to use pumps in patients with Parkinson's disease? Remember what happens in PD and what causes the disability in PD. And like, why do the trials say you have to have Parkinson's at least 5 years to enroll in this trial? Is because by 5 years, you start to fluctuate and have those on and off periods. So remember, by the time you come and see your neurologist, you have lost about 60% of those cells that produce dopamine have already died off, but you've already had PD about 10 or 15 years. But you're coming into the clinic with that 40% of cells that produce dopamine, and it gives you that buffering capacity so that you can start a short-acting levodopa like Sinemet that only has a 90-minute half-life and not notice anything. You just take it 3 times a day. You could miss the noon dose. You can have a turkey sandwich for lunch and nothing happens. Everything still works the same. But 5 years into the disease, once you've used up that 40% of cells that still produce dopamine, they're all gone, and all of the dopamine comes from your medication, then you really notice if you're on a short-acting levodopa or a longer-acting levodopa. And so if it only lasts 90 minutes, then your motor symptoms and non-motor symptoms of PD start to come back. That tremor, rigidity, trouble with gait and balance, that freezing of gait comes back. And not only those motor symptoms, but non-motor symptoms like fatigue, anxiety, depression also come back. And so that's what causes the disruption in the day. And you have these peaks and troughs throughout the day, every 3 to 4 hours. So then we try to stretch that out by adding Rytary, or long-acting form of levodopa, and adding all of these adjuncts, these dopamine agonists, things like Azilect or Razagiline, which is an MAOB inhibitor, to try to stretch that out as long as possible and give you as much on time per dose as we can, so that you're not planning your day around every single dose of levodopa, which is what happens to patients as the disease progresses. So if you're on a pump, you have a continuous infusion of the medication over the 24-hour period. So you don't notice these peaks and troughs as often. So let's take the Duopa pump. It gives you a little squirt of levodopa every 57 seconds. So you're always getting a little bit of medicine throughout the day, and you're less likely to run out, and you're less likely to notice an off period if you do something like physical therapy or rock steady boxing, or you eat a turkey sandwich. That trough is not as deep as if you were taking a pill. And what happens with pills in Parkinson's disease? Remember, in Parkinson's, you have bradykinesia, or slowness of movement, and that affects all of the muscles of the body, including the muscles of the gut. It's the reason why PD patients have constipation. That gut moves really, really slowly. More fluid gets sucked out of the stool gets hard, and you get constipated. And once you're constipated, that gastrocolic reflex doesn't work. So you swallow the pill, and instead of migrating into the small intestine where it actually gets absorbed, it could sit there for 2 hours and do nothing. So if that pill is sitting in your stomach, it might as well be sitting on your kitchen counter. It's not doing anything until it gets into the small intestine. And most PD patients are constipated. So you're always battling that, what we call delayed on. I swallowed my pill and nothing happened. And so if you have a pump, if it's Duopa, we have a little PEG-J that goes straight into the jejunum, into the small intestine, that bypasses the stomach. If you have a subcutaneous pump, you're going through the skin, you're bypassing the gut altogether. So we're less worried about your gut motility, whether it's slow, if you're constipated, what you ate, and when you ate it. Because the pills, once you swallow the pill, we have no control over that pill. It could be stuck there. If you swallow 2 pills because you got anxious, you're like, it's not doing anything in 30 minutes, you swallowed another pill, and then they hit the small intestine at the same time, and now you have dyskinesia. And if you're on Rytary, that dyskinesia and involuntary movements could last for 4 hours. We can't do anything except to wait for that medicine to be metabolized. But if you're on a pump, and the pump also has a little extra dose button built into it. So many patients are on rescue medicine or on-demand therapy, like Ambrosia or Apoquin, that bypasses the gut. So the pumps all have that extra dose button already built into it. And so that if you wanted to eat a turkey sandwich, or you wanted to go to rock steady boxing, then you can add a little extra dose to that the medicine, and have a little extra gas in the tank if you needed it. And then if you add, let's say you squeeze that button a little bit too many times and you became dyskinetic or wiggly, all we have to do with the pump is turn your flow rate down or turn the pump off. And then 20 minutes later, your dyskinesia is all gone. So it gives you much more control over your dose and your therapy, and therefore your disease, with a pump than you do with oral medicines. So let's kind of go through the different kinds of offs and how the pump helps you with that. So we talked about delayed on, that you swallow the pill and it kind of sits in your tummy for 2 hours. With a subcutaneous pump, we're going through the skin. We don't have to worry about what's going on with the pump, with the gut. If you're on Duopa, it has that little PEG-J that goes straight into the jejunum. And you have that extra dose button that helps you overcome eating a high protein meal, or if you're going to exercise. So remember that your levodopa, it's like gas in the tank. So if you're going to drive your car at 80 miles an hour, it's going to use up more gas than if you drive at 50 miles an hour. And that way, using a pump, we're continuously giving you the medicine. You're always getting medicine. You're always putting gas in the tank. So you're less likely to wear off or run out of gas, if you're doing a high intensity activity like Rock City boxing, or if you're stressed out about buying all of your Christmas presents and the 21 stockings that you have to get together, you've got that continuous therapy going on. So you're less likely to have an unpredictable off, which is what happens with the pills if you're using them up too quickly. We can take care of delayed on by using that extra dose button and bypassing the gut because it's subcutaneous. Then patients have end of dose wearing off, which is the most common reason why your doctor goes from 3 times a day to 4 times a day or adds another dose of levodopa, is that it doesn't last as long anymore. And so a medicine that used to last 4 hours is only lasting 3 hours. Well, if it's continuous, you don't really notice that wearing off because you're on a pump. And then morning off. Many patients take medicines during the day. They're putting gas in the tank every 3 or 4 hours. They're using once a day medicines, but when they wake up in the morning, they haven't taken anything throughout the night and they wake up off, and it takes a long time for that first dose of medicine to kick in. It's the most common reason why we start the day in some patients with an on-demand therapy like Ambrosia or Apokyn and their dose of Rytary. Whereas with a pump, let's say today's pump of Duopa, it has a morning dose. So it gives you a morning bolus, gets you up into that therapeutic window right away, and then it puts you into a continuous dose. The pumps next year will be FDA approved to be 24-hour pumps so that you can just use them throughout the day and the night. And there's no more need for a morning bolus, so that you can just be on the minute you wake up and get dressed and bathe. And so that's how the pumps are a better fit for Parkinson's disease, just like an insulin pump is a better fit for a type 1 diabetic than using a sliding scale insulin, which is what Sinemet is. So any questions that you guys have about versus oral medicines, pills versus pumps?
Okay, one did come in. You said Duopa delivers every 57 seconds. Is that about what the subcutaneous pumps will deliver levodopa as well?
Probably, I don't know how many seconds for each pump, but it'll be the same kind of
Same
idea.
concept.
Yes. So that it's continuous. So remember what happens in PD, you peak and trough with the metabolism of that oral medication. And because the medicine is the same, but your therapeutic window gets smaller and smaller, that buffering capacity gets smaller and smaller, you start to peak above your therapeutic window, and that causes dyskinesia. And then you trough below your window, and it causes the off periods. And so you're always on and off, on and off. And what we want to do, especially in advanced patients where that therapeutic window is very, very small and tight, is to give you a pump that it makes it easier to stay in that therapeutic window, so you're not bouncing up and on and off all day long.
Very good. And someone asked, if you have Duopa or DBS, could you still get the new pump when they come out?
Yes. So in fact, my best patients are DBS Duopa patients because they have continuous therapy both chemically and electrically with DBS. And certainly everybody who's on Duopa now is anxiously awaiting phospholevodopa. We're not going to pull the tube right away. We're going to make sure that you tolerate the subcutaneous infusion of levodopa, of that phospholevodopa, because some patients develop an infection or some granulomas. But if you do well, then we would go to the subcutaneous pump and then eject the Duopa pump. But I think actually the use of Duopa is actually going to go up next year, not down, because once patients are on continuous therapy, you kind of forgot what it was like to have a body that worked 24 hours a day and how much off periods you actually had. And so once you're on a pump, it's very difficult to go back to oral medicines and go back to that on and off, and it's not predictable anymore. And so that patients who didn't tolerate the subcutaneous delivery of the medicine will then opt to have Duopa and have a more continuous delivery of the medicine, therefore more predictability in their day and less disability. Because once you start to plan your day around every single dose of levodopa, you stop doing stuff because it's just too hard to figure out when is my pill going to kick in and how long is it going to last.
I've seen some people's spreadsheets about when they take their meds, and you have sent them to me, some of you out there, and they are amazingly complex and amazing that you have figured all that out. But that's what resonates with me when you say getting back to that, what full life feels like.
Right. And
so we had,
ideas that we want to divorce you from the 6 alarms on your phone and your notebook and being worried about what you're going to eat, is how much protein is it in that turkey sandwich and all of that kind of stuff, just to stop thinking about Parkinson's.
That sounds like a great divorce. Divorce is never good, except in some situations like that. So there's 2 questions that I'm going to kind of combine. Why can't you just drink the Duopa or the pump solution? And then 2, how does it pass the blood? How does it overcome the blood-brain barrier?
Yeah, so in fact, 20 years ago, we would make a little cocktail and patients would sip. So that we would grind up your cinnamon and grind up your ropinirole and put some vitamin C in there, and you would sip this little cocktail all day long. But it's just really difficult to have that. It's much easier to have it in a pump and have the pump do all the work for you, and that you're not sipping this little cocktail. And that's what we used to do 20 years ago when we didn't have DBS, we didn't have dopamine agonists, we didn't have razagiline, and literally patients were taking Sinemet every 90 minutes. And so that was very difficult. So we've kind of advanced from there. So we would use a pump. So it's just easier to manage. And then we don't have to make this concoction for you anymore. But we did used to do that. And then, so how does it cross the blood-brain barrier? So with levodopa, remember levodopa, we can't give you dopamine because dopamine doesn't cross the blood-brain barrier. So we have to give it to you as a prodrug, levodopa, that then gets converted into dopamine. And then that the levodopa can cross the blood-brain barrier. But then there's 2 enzymes that chew up your levodopa before it gets to the brain. So that's how Sinemet became what Sinemet is. So levodopa, then we added carbidopa to that, and that blocks dopa decarboxylase, one of those enzymes that chews it up. So before, remember, some people, that have been to my lectures know that it's only less than 5% of that levodopa in your yellow Sinemet makes it from your tummy to your brain. It's almost nothing because it all gets chewed up in the periphery. So once they added carbidopa, then we could, instead of giving you 1 gram of levodopa, we could give you 100 milligrams of levodopa and then have that sort of cross the blood-brain barrier. And then you didn't get all that nausea and vomiting that you had. So that's how Sinemet got its name, Sinemesis, without vomiting. And so we've had carbidopa, levodopa for a very long time. And then the other enzyme that chews up your levodopa in the tummy before it gets to the brain is COMT. And so patients who are on opicapone or on Gentis or entacapone or Comtan, that blocks that enzyme. So most of that levodopa then makes it to the brain, but it's still competing with protein in your diet because it uses that same little elevator from the tummy to the brain to cross that blood-brain barrier. It uses that same elevator. So that's why you notice that competition with protein in the food. The nice thing about apomorphine, which is a dopamine agonist, remember dopamine agonists, they'll go and they'll sit on the same receptors as dopamine, but chemically they're not the same chemical. And it doesn't use the same little elevator. It can going to shoot straight up into the brain and bypass all of those enzymes that chew up levodopa. And so apomorphine, which will be the first pump out, will bypass all of that and go straight to the brain. And so that we don't have to use as much of it. So you'll see that pump is a little bit smaller, and we don't have the competition with food and protein and those 2 enzymes that need to be blocked to make more of it get to the blood-brain barrier, get to the brain. So that's how like levodopa makes it from your tummy to the brain.
Oh, that's so good. So agonists take a different elevator.
Yeah, they get VIP status and they go straight up. There's no metabolism.
They're
There's
that
no
special,
right.
in Vegas, you have like the VIP elevator. Okay, agonists take that. And then that's also a great metaphor that you said that the dopamine the levodopa gets eaten away. So the COMT inhibitors, the other things, they prevent it from getting eaten up before it gets to your actual system.
Right. And so then we actually got good news. So Amneal, the people that make Rytary and that are going to come out with IPX203, which is a longer acting form of Rytary, they have picked up on Gentis so that we're not going to lose it this year, so that we will have that going forward as well. And so on Gentis is opicapone. It's a COMT inhibitor that's once a day that that blocks that second enzyme that chews up levodopa in the tummy before it gets up into the brain. So at least we're not going to lose that drug like we're using, you know, we lost Kinmobi and Parcopa this year because people weren't using it. So that's the other thing. You need to go into your doctor's office and say, hey, there's all these new drugs out there. I need to be on them and use them. We don't want to lose them. You know, we want to be on the new good stuff that lasts and works longer and better than the old stuff that we've been using since the 1970s.
Wonderful. So Kate has a question. I hope you didn't forget it, Kate, because it's been a couple minutes since you raised your hand, but I think you're unmuted and go ahead. Are you out there, Kate?
Can you hear me?
Yes. Hi.
Hi. I was diagnosed a couple of years ago, but I think I must have had Parkinson's years before that. At any rate, my modus operandum is to take the carbidopa levodopa about an hour before I get up, and I go back to sleep. And then I'm just wondering, is it moving through my gut if I'm sleeping? That's my main question.
Yep.
And my other question is, if I'm using carbidopa levodopa, if I add an extra dose, does that mean that in the future I will be shortchanged? Over.
Yep. Yeah. So yeah, still moving through your gut, whether you're asleep or not. And so, but today, you know, you don't have, that's what you used to do in the past. You'd wake up, you take your dose of Cinemet and then go back to sleep and wait for it to kick in for you to start your day. Today, you can start your day right away using an on-demand therapy and your oral Cinemet at the same time. So you can use Ambrosia, which is an inhaled form of levodopa that goes lungs to brain. So it kicks in 5 to 10 minutes and it lasts about an hour. Or you can use Apokin, which is apomorphine, a dopamine agonist that you inject like an EpiPen to get you started right away. So you don't have to go back to bed and wait for that pill to kick in. You can start your day right away with an on-demand therapy and your oral Cinemet. And that on-demand therapy is going to work for you while that oral Cinemet is making its way through the gut. And so levodopa is very forgiving. So many patients always ask, gosh, you know, I read on the internet that after a couple of years it stops working or that I shouldn't start it right away. So the reason that you notice that levodopa doesn't last as long 5 years later, it's not that you've developed a tolerance to the medicine or habituated to the medicine, is that you're making less of your own dopamine. And so we have to add more of it to get the same job done. So you can take levodopa without any problem. And if you need an extra dose, that's perfectly fine. We're just putting more gas in the tank to get you through your Rock City boxing or your physical therapy or whatever, or your Christmas shopping. So you can take a little extra levodopa. It's very forgiving. So the reason that you notice the fluctuations and those motor on and offs is just that you've lost your buffering capacity. So think of it, when you come and see your doctor, you've got a savings account of dopamine and a checking account of dopamine. The checking account is the medicine that your doctor gives you, whether it's a small little paycheck like Cinemet or a longer, bigger paycheck like Rytary, or you could have a credit line, which is a pump. But your savings account, so the reason that you don't notice those off periods during the first 5 years of the disease is that overdraft is taken from your savings account. So you don't notice that the Cinemet only had a 90-minute half-life. But after 5 years, you've overdrafted, you've used up all of that savings account and there's nothing left in there. Those 40% of cells that make dopamine are all gone. And so all of the dopamine now comes from your medicine. And so you really notice, do I have a long-acting medicine like Rytary or IPX203, or do I have a short-acting medicine like Cinemet? And so what do you want your boss to give you? A big paycheck, you know, at a predictable time every time in the month so that you know how to pay the bills. So that's what Rytary and IPX203 are. Or you could get a credit line, which is a pump, so that you always have that money flowing in, that gas flowing in, and you're not running out of gas throughout the month.
Can I ask one more thing about this?
Of course.
I've been wavering between, or I've tried the extended release as opposed to the immediate release. And the other day I forgot my immediate release and I went swimming. And when I came out of the pool, I ended up having a big fall. I wonder if it's more dangerous to deal with the immediate release because of the possibility of that kind of reaction. Whereas perhaps the extended release doesn't give you that important a reaction if you forget it.
Yeah, so you always want to be on the longest acting form of levodopa that you can get your hands on. And you want to use once a day medicines if you can use them because of that gastroparesis, that slowed gut. So that we only have to migrate that pill from the tummy into the small intestine once a day instead of every 3 or 4 hours. So the longer acting form of levodopa that you have, the longer on time per dose you have, and the less likely you are to wear off during an activity like swimming. So you just have to sort of change, and many patients use immediate release and extended release and Rytari all together. They sort of mix and match and see what combination works the best for them.
Okay, thanks, Kate. And Dr. Ospina, now we have a few questions on dopamine agonists. And so DILIP, actually, even I know this, pramipexole is not the same as carbidopa, levodopa. But there were some questions about the negative side effects of using apomorphine as a monotherapy. And then there's another one in here about the pump and will it exacerbate addictive behavior? So just because you're a pro, I'm going to mash up multiple questions and send them your way, Dr. Ospina.
So that's a super important question. So remember, the dopamine agonists that we currently have on the market are pramipexole or Mirapex, Requip or ropinirole, and Nupa or rotigotine. All of those are super dirty drugs. They hit all of the dopamine receptors, including D2, D3, what causes impulse control disorder, hallucinations, confusion, all of that stuff. All of the new drugs, all of the new dopamine agonists that are come out in the future are going to be D1, D5. So they're just going to be more motor, not have that D3 where we have a lot of the side effects of impulse control disorder and hallucinations. So apomorphine is D1, D5. So we're less likely to worry about impulse control disorder in those patients than if somebody who was on Mirapex or pramipexole. So, I mean, it's always something that we're going to be watching out for, but it's less likely. And in fact, in the clinical trial for apomorphine, they had less hallucinations than patients who were on the levodopa. So it should have a cleaner side effect profile as far as the dopamine agonist is concerned, and less hallucinations that we're seeing with patients using levodopa. Apomorphine as a pump will not be approved as monotherapy. It'll still be approved as an adjunct, whereas phospholevodopa will be approved as monotherapy, I think. But our worry is less of those dopamine agonist side effects of the dirty drugs, like pramipexole and ropinirole. But it's something that we'll worry about. But it's less of a problem. And then the oral, there's going to be a pill too of a D1, D5 that's once a day that will come out. And so that should be a much cleaner side effect profile, less likely to cause impulse control disorder, excessive daytime sleepiness, hallucinations than the current dopamine agonist on the market.
Thank you. And then there were two, it's tough to keep track of the news and things coming out. So there were two that I think are maybe just clarifications. So someone asked about the carbidopa levodopa patch that is being developed in Israel by Neuroderm. I believe, do you know about that, or is that Neuroderm pump?
Yeah, so the Neuroderm pump, so that might be approved in the first quarter of next year as a compassionate use so that patients could use it. You'd have to pay for it. It wouldn't be paid for by Medicare, but you could use the therapy until it gets approved. So they're kind of like the last, I don't think they've submitted to the FDA. I don't think they have the PDUFA date yet, but we might have compassionate use. And so it would be a levodopa pump that's subcutaneous, kind of like the AbbVie pump, which will hopefully come out the second part of next year.
Okay, and then another clarifying question from Rod, is the subcutaneous pump the same one they took off the market last year because it caused skin problems?
So it wasn't taken off the market. It hasn't made it to the market yet. So all of the pumps have skin issues. So Duopa has a stoma, so you need a little medication port for the PEG-J. So the stoma can get irritated, it can get infected, it can weep. You have to sort of maintain it and clean it. With the subcutaneous pumps, so the levodopa pumps have a little bit more incidence of things like infections, whereas the apomorphine pump is just more erythema, redness, and maybe some granulomas. So those are the issues. So some patients will not be able to tolerate those pumps because they have an allergic reaction to the medicine in the skin. Other patients, if they tolerate the pump quite well, then they stay on the pump for years. So apomorphine pump has been available in the UK for 30 years now. They've used it very successfully for a long time. The AbbVie pump, I think, is now available in Japan. So for the patients that it works and they don't develop an infection, it's going to be a very useful drug. In those patients, then we can try apomorphine, or we go back to orals, like things like IPX203. So it's something that can be managed. So the skin issues are there, just like a type 1 diabetic also has granulomas, and you have to keep the site clean and dry, and you have to rotate the site. So the same, it's like the Nupro patch, you rotate it so the same little area of skin doesn't get irritated or red. The same thing we would do with the subcutaneous pump. We just have to move it around every 3 days.
Okay. And 2 follow-up questions on dopamine agonists. Do they address non-motor symptoms, first of all?
Yep. And so like one more thing I want to say about the pumps is always with every medicine or therapy, we want to make sure, do the benefits of the medicine therapy outweigh the side effects of that therapy? That's why the pumps are not going to be first line. We're still going to give you Sinemet or Rytary or IPX203. And then once you're on orals more than 4 times a day, your 5th dose should not be another 5th dose of an oral medicine that's going to get stuck in the tummy. That 5th dose should be a pump, because then whatever side effects you have or irritation you have in the skin is worth it, that taking another dose of levodopa. So that those off periods, so that you're not planning your day around every single dose of levodopa. So that's how we're going to think about the pumps, and where we're going to put the pumps in sort of the clinical picture of Parkinson's disease. And then the other question about dopamine agonist. Yes, so your levodopa, it helps non-motor symptoms, but many times your therapy makes non-motor symptoms worse. So they all drop your blood pressure, make you more orthostatic or dizzy when you stand up. They can make you more constipated. They can make you confused. They can make you hallucinate. They can make you compulsive. And so our job is to try to get that balance just right, so that you have enough medicines on board that you're mobile, but not so much that every time you stand up, you feel like you're going to faint, or that you're hallucinating, or that you're falling asleep at stop signs, or that you're doing a lot of one-click Amazon shopping at 2 o'clock in the morning.
And when it comes to 2024, I know, the FDA sometimes is, we can't control them. Who knows what they're going to do? What can the people on the call expect? What's going to come on the market? What's going to change in terms of therapies they should talk to their doctors about? So I know you don't have a crystal ball, but could you summarize what 2024 might look like for treatments and medications that's new?
Yeah, so as we said, Ongentys is going to stay on the market now because Amneal has bought it and is going to promote it. So we're not going to lose Ongentys. So Ongentys is that once-a-day COMT inhibitor. Remember, it's that other little bodyguard that inhibits the metabolism of levodopa in the tummy, so more of it gets into the brain. So that's going to stay on the market. Then if we're lucky, if everything works the way it should, then in April, May, we should have apomorphine approved. That will be the apomorphine subcutaneous pump. Then after that, we should then see the AbbVie phoslevodopa pump and IPX203 approved around the same time. So IPX203 is the long-acting form of Rytary. So it's a six-hour version of levodopa, which will be a capsule. And then phoslevodopa will be like the Duopa pump, but instead of having a peg, it's subcutaneous. And then the last pump that would come out would be Neuroderm, which is also a levodopa pump. So those should be sort of the 4 things approved. And then maybe early 2026, we'd have an oral once-a-day dopamine agonist that's D1, D5.
Okay. And through it all, PMD Alliance will be here to remind you, to announce what's coming out, and to give you tools and resources, how you can ask your doctor about it and have those conversations. So we'll be here with you through all of 2024, along with Dr. Ospina, and so many good metaphors, like David said, between the checking account and the bouncers and the elevators. David said your deep understanding converted to simple language is so helpful, and I couldn't agree more. So thank you so much for joining us and breaking down what's new, and also with Mike, what you can do right now to enroll in clinical trials. People encourage them to enroll. We really appreciate Dr. Ospina and Mike joining today. So we always like to close with some eye contact and some gratitude. So if your camera has been off, I invite you to turn it on and do a wave of gratitude to show Dr. Ospina and Mike, that we're here, we're listening, we're a community together, learning and celebrating the holidays. So thank you, everyone. And thank you, Dr. Ospina, so much.
Take care. Bye-bye. See you in the new year.
Bye, everybody. Thank you so much, everyone, for letting me stop by on this one.
Thanks, Mike.